much, Dr. Song. So now I would like to invite my teacher, my hero, my mentor, Dr. Abbasi, to give his talk on transcambin oblique posterior lateral lumbar interbody fusion technique. Thank you, Dr. Abbasi.
Thank you. So first of all, if you don't mind if you connect it for me.
Yeah.
After listening to you all, I decided to change my talk completely. And I'm going to do that all in 13 minutes. Now, there are a few things I need to let you know. Number one, what I'm going to talk to you is just another tool in your tool set. It's not going to replace everything else you know. Because when I go and so enthusiastically talk about that, people think this is just the one hammer I got and everything is nailed. It's not. Number two is that what I'm going to present it to you is based on, as of yesterday, 1,818 cases and 3,500 levels. So this is not a 30 case result I'm introducing to you. Now please, you will connect that. And then the last thing I want you to have it in the forefront of your mind is that everything I'm going to show to you is replicable. It's teachable, it's learnable, and as a matter of fact, I have 10 years data after I've been teaching this for 270 surgeons. Every other surgeon has 5 to 7 times faster, more efficient learning curve that I have. Like Dr. Gasco is doing now scoliosis cases after 200 cases, whereas I started doing high-grade scoliosis after 800 cases. So this is, I want you to have this fact in front of your mind.
This is coming.
So
is important.
let's just use this. That will just work by pushing it right there. Let's see if that works. Yes, here we go. So, having said that, let's just start. We have very little time. If you are not, look us up, join us. We are already now over 1,100 members in our society. And spine is a public health issue. This is the first part of my talk. Why what I'm telling you is important. According to Becker Spine, 1.62 million instrumented spinal fusions are performed in the United States. This is going to break our bank. This is, after what you have talked about, we cannot just keep going the way we are going right now. And this is what hospitals think. They're afraid of people who try to move spinal fusion to surgery centers. Now, we talked about the financial. If you want to save money in the spine, move it to surgery center. Just was talking to Kevin Foley the other day, has all the data. You move any surgery from hospital to surgery center, you cut the cost in half. That's what we need to do. Move it to, and this is, hospitals are scared because they think we are going to move all these money makers to surgery center and they are going to go bankrupt. But the reality is that with the same technology, all of a sudden we can take care of the patient that we couldn't take care of until now. So it won't change. Hospitals are scared of surgery center, but they shouldn't. Now, remember the 3 things I told you before, okay? This was my surgery center yesterday. We got done actually ahead of the time at 1 p.m. I just added this slide. And these are complex fusion I'm talking about. We do complex 3-level fusion on high BMI in our surgery center, and we send them home 2-3 hours after the surgery. I couldn't be here if this patient would stay in my center. They're all discharged within few hours. This is a regular day. And this place is in Kansas where we practice. We have a new practice there. This is a glorified surgery center that we can do complex cases and send 96% of the patient home within 24 hours. If you want to talk about cost saving, this is how you save cost, by providing more care to people who have no other choice, keeping them ambulating and with a fraction of the resources that you would need. Now, it's not about the skin incision. This is not the second part of my talk. It's not about the skin incision. We talked about all the muscle you don't cut. That's what makes that surgery less invasive and a surgery center case. You don't disrupt the autoregulation. You don't disrupt the vascularization of the bone. TLIF, my patient in 2012, everything is scarred. When you ever go back there, everything is scarred. Where I did the adjacent segment OLLIF, everything is pristine tissue. This patient just recover faster. They don't need all the things that make them impossible for them to go back to their life. So I'm going to bypass a few slides here in the efficiency, to be efficient myself here in this talk. Every additional half an hour under anesthesia alone adds 17% to the combined risk of the surgery. This needs to be repeated. Every additional half an hour under anesthesia adds 17% to the combined risk of the surgery in every category you can imagine. So, and the two procedures that I'm specialized in are OLLIF, the transcamin OLLIF, and MIS-DLIF, practically prone lateral. And as we just discussed, we have a tremendous number of data here that, and that is why I can do it in a surgery center. 95% of my procedures are under 2 hours. Now, I'm going to show you as well that compared to other surgeries, we have done, this was part of value-based purchasing in the hospital when they invested in this procedure. That whereas, like in the blue line, the regular TLF with a higher BMI become more complex surgery. MI's TLIF can be very efficient, but as well in the high BMI become more difficult. In this procedure, like in endoscopy, because you're working through a tube, it doesn't matter if you go through 2-inch or 6-inch of fat. You can perform at the same level. Now, I'm going to show you 2 more slides and then show you a video instead of going through the procedure. 96% of my patients, even elderly, even BMI 55, ambulate within 24 hours. That's why they can go home independently. They ambulate independently within 24 hours. So I'm going to, and another thing, last thing, I was very appreciative of the economic talk. You don't need $1 million robot and a $500,000 maintenance fee to do that. What you see here is all you need to perform the surgery. That is, when I go to India to do live surgery, I have a bag smaller than Amanda's bag, and I carry it with me, and I go and do 5 surgeries with a small bag. This is all you need. Now, regarding the surgery itself, obviously you need certain setup. All of that is, we protocolize it. It's very algorithmic. And I'm not, instead of showing this, this is the last part of my talk. So I'm just going to show you actually a video of the actual x-ray of the surgery. And I'm going to explain to you on that. So first thing I do, I put a Jamshidi in the bone and I get some bone marrow, then a neuromonitoring probe, as you see here, which is insulated with Teflon and has a metal sleeve over it. Only the tip is exposed right here. I go with a similar, very similar, measurement to the Camin triangle. As a matter of fact, I aim for the pedicle of the level below. As it was mentioned, the nerve root is almost attached to the pedicle of the level above. Then I slide it down. I stimulate at 3 milliamp. I go down to 4 milliamp. Then the sleeves come down, and then a K-wire goes in. And then a dilator goes in and open up this space. And then over this dilator, then a working cannula, which is 10 millimeter outside and 8 millimeter inside, goes in. And all the work is done through that working cannula. All those instruments you saw, they're specifically made to go through that 8 millimeter cannula and do discectomy, prepare the end plates, and so on and so forth. And then a cannulated cage get inserted. What you don't see here, from beginning of this surgery to this point, is 7 minutes and 40 seconds. That is what you don't see. But Uzma has been in my surgery, and Dr. Bashir has been in the surgery. We don't rush it. It's not about trying to speed up or cutting any corner. It's just, you don't do the regular thing where you cut the muscle, you stop the bleeding, you move forward. You repeat that until you are where you need to go. And like endoscopy, you are there exactly where you need to be with minimal effort. And again, everybody who has joined us after just 10 cases, they fall below 1 hour for one level of surgery, skin to skin, every single of them. So it's nothing really specific. It's not, you don't need superior skills. You don't need like Kevin Foley's of the world to do that. Everybody can replicate this. Now, the rest of this surgery is just a posterior instrumentation, which is with a tower screw and so on. And the question I'm often asked, can you do discectomy? Does it fuse and so on? Does it work and so on? Well, we have published 12 papers. If you're interested, I can send you the references and the links to those papers that you can see. But one question is always asked, can you do discectomy? Once you get used to the instrumentation, you do as good of a discectomy than with any other tool, except you don't have to go with the sharp tool next to the dura and the nerve root 50 times in and out. Now, our blood loss is usually in tens of cc's. Our hospital stay we have all the data is 1.6 days in average, whereas regular hospital stay for similar procedure in any hospital in our area is about 3.8 to 4.2. Risk of infection after 1,818 cases is 0.3%, whereas just our society's neurosurgical board sent us a paper that the risk of infection is somewhere between 5 and 8% for similar surgeries. And durotomy risk is 0. You're not even there where the dura is. You're all through transcambine approach and so on. So I'm going to stop here because I think I want to stay within my initial promise to stay under 13 minutes, but maybe I have 2 minutes for 1 or 2 questions. Thank you.
Thank you very much for the great talk. One of the things I always worry about, especially even with uniportal, transforaminal, is the DRG, and if the disc space is quite collapsed or subluxated from angiosthesis, injuring the exiting nerve root. What are your thoughts on that? Are there cases where you're like, ooh, that's too collapsed, or that's too much? I don't know if I'm able to do that safely without injuring the nerve. And then also, second question is, what if there's a very hypertrophic facet? Do you do anything with that before to get a better access point?
So, question number 1, rate of nerve root injury. And we have extensive data comparing to all the other, including lateral and so on. Initially, the rate of, we categorize them in 2 categories, nerve root irritation and neuropraxia. The rate of nerve root irritation is about 12%, including the learning curve, but then it drops dramatically lower after the learning curve. The main factor for nerve injury is L5S1, has higher rate of, and then some other factors as well. The size of the cage surprisingly doesn't really correlate with that. The rate of nerve root damage after a year is under 1%, which is very comparable to TLF or any other. As a matter of fact, it's comparable to macrodiscectomy. So, but again, it's about learning curve. Now, the second question is, who's a good candidate, who's not a good candidate? That's how I understand your second part of your question. I didn't start with this. You start with L1 to L5, and then you work your way up, and then eventually you publish a paper about what we call transfacet OLLIF, where you go actually take the part of the facet off before you enter that. But once you add some of these peripheral tools to your toolkit, you can go from this to this, correct the scoliosis, make the sagittal alignment by putting the location of the cage, and so on and so forth. With this, on a patient that under 2 hours, on a patient that 4 other surgeons legitimately said she cannot have the surgery because she has cardiovascular problem that a regular surgery wouldn't be really possible. The indication grows with your level of experience, and you do have to modify it. This is like, I would say it's like one of those trucks that you have to adjust and upgrade based on your specific needs. It's just a platform that gets you through cambine triangle to the disc to enable you to do whatever you need to do. Put the cage right and left for chronal deformity, put the cage front and back for sagittal deformity, and eventually, you know, even do if you want to include as well, like full endoscopic version of this is it's called OLLIF. It's been performed, and I have been in India. I was amazed how many people are doing that now in India. Just in the last 2 visits I have been there, I gave few cadaver lab. Now about 60 surgeons are performing it. It's growing. Now in 2025, this is not the only tool you have, but you have to add a transcambin tool to your repertoire, to your toolkit.
I've been following your work. Really pleasant to be here with you. And what is the most diagnostic dilemma in your experience? And the second question is about the osteoporotic patients.
Mm-hmm.
Well, how do you deal with them?
Okay. Now, I understand the first part of the question to be, what is the main problem I've encountered with that learning curve, especially in L5S1. Like in endoscopy, but this is, and I was so appreciative you telling what the learning curve was, right? You said something between 30 and 50. We made a science of it. I'm a pilot. Even if you do piloting, something completely medically unrelated, you have to take off and land 25 times minimum, because that's what Federal Aviation Administration requires. Our brain is hardwired. You need somewhere between 30 and 50 exposure to do that. Now, the problem that I encountered is that nobody was there to tell me how to do that. I had to figure it out myself, and that was a big deal. That is why we did a study. Most of people who learned that after 5 to 7 cases, over 90% of them stopped that because that's where they failed. Because we haven't structured it in our learning, in our academic life and so on. That has to really change, that we create a secure environment to teach it. That is why we have put the so-called soft transition. We started our society. We have now multiple cadaver lab. I go to India, multiple other countries to really teach that. That is important. Now, the second part of your question, I think it was about, can you repeat the second part of the question? Osteoporotic patient. Now, initially, I didn't, that all comes to, do you believe in indirect decompression or not? As a matter of fact, I think if you do ACDF, you have to believe in indirect decompression. We published a paper about that we call it anatomic physiologic decompression by restoring the height of the disc, you're opening up the foramen and lateral recess. As a matter of fact, if you increase the interdiscal space 2.5 millimeter, you're doubling the area of the lateral recess and foramen. And when I started doing that, I was over-distracting. And with those, especially with those osteoporotic patients, it's about being just gentle with the indirect decompression. Don't try to over-distract, because that's when you break into that. Now, having said that, in any muscle-sparing procedure, the osteoporotic patients are the people who benefit most, because you don't do all the collateral damage. You know, I've had a slide that vascularization of the bone is through surrounding muscle. In a regular, non-muscle sparing technique, you are devascularizing the muscle to the 25% of the original value. Here, you keep all the vascularization. This is specifically the procedure that the osteoporotic patient benefit most. But don't over-distract. Okay, well, thank you very much. Absolutely. You remember, I started with saying this is just one more tool in your toolkit. It doesn't. OLLIF is a beautiful surgery, but OLLIF is a surgery, mostly is an access surgery. If you have a good access surgeon, okay, this is, I have to say that before I go, because I think this is important. OLLIF was my way to go kind of procedure. And I had a good access surgeon who gave me 25-minute access to L5S1. Beautiful. I love that procedure. It's still the most beautiful surgery. I went to a new place where my access surgeon needed 3.5 hours to get access to L5S1. That surgery completely changes. It's not the same surgery anymore. And that is why I started 15 years ago looking for alternatives. Thanks to that access surgeon who needed 3.5 hours, I started looking for alternatives, and 15 years later, here I am. Okay? Thank you.